Our next group of speakers are Dr. Susan Puumala, who is the principal investigator on the CRCAIH research project, Emergency Department Use and Care in American Indian Children. She is an epidemiologist in the Center for Health Outcomes and Population Research at Sanford Research here in Sioux Falls, and an associate professor of pediatrics at the Sanford School of Medicine of the University of South Dakota. Dr. Puumala earned her PhD in epidemiology at the University of Minnesota and her master's in statistics at Iowa State University. Brianna McMichael is a clinical research coordinator in the emergency department at Children's Minnesota, and Brianna completed her Master's of Public Health from the University of Minnesota in Community Health Promotion and Public Policy. And Wyatt Pickner is graduated from the University of South Dakota and is currently pursuing a Master's in Public Health at the University of Washington in Seattle. Previously, he worked here at Sanford Research as a research associate on the Emergency Department Study and the Methodology Core. Today, their presentation is Developing Interventions in Emergency Care for American Indian Children. Please welcome the trio, Dr. Susan Puumala, Brianna McMichael, and Wyatt Pickner. Thank you.
All right, so we have three of us, so we'll be getting up to talk at different times. And I think my slides are already advancing themselves. But I'm really pleased to be here today. Thanks for having us talk. And I'm glad to have Wyatt and Brianna here too. It really shows that this project that we did had a ton of people involved with it. And so it's nice that even our presentation is a collaborative effort between the team members. So what I'm going to do in the first 5 minutes is talk about the first 2.5 years of our study and what we did to kind of set up development of our interventions. And what we really want to get to is our interventions themselves, what we did, how we set them up, and some of the preliminary results from those. But I wanted to tell you a little bit of a story of how we got there and talk about some of the work that we did prior to setting those up. Okay, so I put this quote up here, again going back to the overall theme of our Collaborative Research Center for American Indian Health, looking at social determinants of health. So thinking about what goes on in the social factors, racism, poverty, lack of healthful food, homophobia. So thinking about those effects and how it can impact health and interaction with healthcare. So the first thing I'm going to talk about is our motivation for the study. So I had worked a little bit with Minnesota Children's researchers looking at some of their data from their emergency department and looking for health disparities. So are kids who come into that emergency department treated the same way if they have the same symptoms or if they have the same disease? And so we found some indications that there were differences in how these kids were being treated at the emergency department. And we wanted to explore that further and figure out why that might be. So we already knew from the previous literature that there was a higher use of the emergency department in American Indian children, low insurance rates, potential lack of access to quality primary care, and some other disease risk factors that might indicate increased use of the emergency department. We also had some good evidence for disparities in care, both from the preliminary data that we had looked at from Children's, but also from some other studies that looked at discrimination that found higher levels of perceived racial discrimination among American Indian parents, and within the ED, the potential for empathy erosion, both due to the quick pace of the emergency department, that people are there to save people's lives, and that sort of fast-paced environment relies more on stereotypes or cognitive shortcuts, so it could lead to empathy erosion for particular groups. So how we set our study up was we wanted to take a really good look at the state of affairs in our study sites to see what was the context of care for the emergency department, So we did that with a number of different data sources. So from our partners, we got medical records from the emergency department for a 1-year period. We surveyed physicians and nurses, and we worked with a group called Project Implicit, designing some tools that might detect implicit and explicit bias. And then we held focus groups in all of our communities to get insights from individuals to see what they felt about healthcare in general and specifically their experiences with emergency care. So we had 5 locations with a total of 6 emergency departments in South Dakota and Minnesota, and we had an additional site in North Dakota that served as a pilot site for a provider survey. So we were able to test out some things before we did them in all of our sites. So to highlight some of the things that we found from our initial review, in our retrospective chart review, we did find the same thing as previous studies, that there was higher use for American Indian children. We looked, so our initial study was with Minnesota Children's, which is a large urban site. And so we included rural sites as well as mid-level size cities. And so we found in the rural areas and in the large urban areas that we saw that increase in use. We looked specifically at mental health diagnoses that were received in the emergency department, and we found a different distribution of those by race. And then we looked at people who left the ED without completing the visit. And there was also a higher rate in American Indian children, even for those with triage codes that would indicate that they really need to be at the emergency department. We also looked at one of our sites at possible bias in our triage codes, and we found some indication of that. We found differences in hospitalizations for kids coming to the emergency department for respiratory infections, and we found differences in asthma care. And the difference that we found was the potential excess in care, excess testing in white children compared to other race ethnicity groups. So then we worked with our emergency departments to get buy-in and implement our provider survey using the implicit association test. So we're looking at implicit bias that you might not be, that you aren't conscious of. In this study, what we wanted to do was look at bias towards adults and bias towards kids. Because when we talked with our group of physicians, they felt that nobody was biased towards the kids, that they were biased towards the caregivers. And we found with implicit bias, it didn't really matter. Kids or adults, it was about the same. We also wanted to look at stereotypes, and so we had different questions regarding stereotypes of American Indian children in the emergency department. And agreement with those stereotype questions ranged from about a quarter to a third. And the last piece of preliminary data we had was from community focus groups. So we had 2 to 4 groups at each of our sites, and then we did content analysis of the transcripts of those, and we found different themes that emerged. Transportation was a big theme, lack of transportation primarily. Ability to decide whether you should take your child to the emergency department or not. And then a lot of things about the environment within the emergency department, especially related to education of the providers, inequity, judgment, prejudice, communication, and cultural competency. So this was a really beneficial aspect to our study, to have that direct input from community members and to help think about what interventions might be beneficial in these communities. So I'll turn it over to Wyatt to talk about intervention development.
Okay, so at our intervention development began with holding stakeholder meetings at each of our sites so that we could talk about what we had found through the retrospective chart review and the focus groups, and at those stakeholder meetings discuss possible interventions. And then from there we held several follow-up meetings with the community groups as well as the emergency departments to talk through to talk through the interventions that were being developed and talk through any logistics or barriers in implementing those interventions. And throughout this process, we were able to develop a number of different partnerships within the community. Overall, our interventions covered 2 areas, parent and caregiver knowledge and access to resources, and 2 provider training on a number of different topics that we'll discuss in the next upcoming slides. So at our first site, the focus was on improving interaction between providers and patients, and so we aimed to develop a culturally appropriate communications program for providers. And then, of course, we were interested in knowing the benefit of this type of program, what type of benefit it would have for American Indian children, their families, and as well as providers. So we had 2 hypotheses. One was that our training program, including a classroom-based intervention or classroom-based education and shadowing, would increase scores on a cross-cultural communication scale for providers. And 2, that parents would rate communication higher after, or provider communication higher after the training program had been implemented. So the intervention was at this site was facility focused, meaning that a short lecture or classroom-based education was given to nurses, and we started broad in training with a large group in this classroom-based training, and then we moved to more individual training with bringing someone in to come in and shadow the provider and nurses and give feedback about their interaction with American Indian children and their families. And we did this because sometimes it's difficult to take information that you learn in a classroom and apply it to real-world situations. And so this approach helped to connect the classroom-based training and real-world situations. And then the topics for the classroom trainings were based on the needs identified through focus groups and stakeholder meetings, which included improved communication, specifically how to interact with cultures different from your own. So again, this intervention was focused on intercultural communication and provided classroom training on communication skills and communicating across cultures. The approach also served as an opportunity for providers to get real-time feedback and ask questions to resources that they and get input from resources that they don't normally have access to. For this site, we had 2 primary sets of participants. One was providers who participated in the classroom trainings and shadowing components, and then the parents and caregivers who evaluated the care that was provided for their child. A total of 120 parents or caregivers participated in the pre-survey, and 73 participated in the post-survey. Significant differences were found with an increase in visits with nurses highly rated for communication skills. A subgroup analysis suggested that the largest improvement was seen in families that had an American Indian child, but the difference was not statistically significant. And then no pre-post differences were found for physicians or front desk staff. In evaluating the training program from the provider's perspective, we looked at 2 domains, including preparedness to deal with families from different cultures or experiences, and skillfulness in delivering cross-cultural care. And no significant changes were seen over time. So for our second site, we had 2 aims again. One was to enhance parent and caregiver knowledge about caring for a sick or injured child, which was evaluated through parent and caregiver surveys. And our second aim was to decrease non-urgent visits to the emergency department, which was evaluated through pre and post intervention triage scores. So for this site, our hypothesis were that parents and caregivers would have increased knowledge on using the ED, what to expect when you get to the ED, and how to care for a sick or injured child. Additionally, we hypothesized that the parent education program would reduce the number of non-urgent visits to the ED. Focus group and stakeholder input called for a community-focused intervention approach as parent caregiver education and easy-to-use resources were prioritized needs at this site. So our parent education program was twofold and included 2 rural communities. We started with a marketing campaign to provide information to parents about using the ED. From there, we developed lunch and learn series around the materials that were developed to go in depth with the communities that we were working with to talk about the content and make sure that they had a good understanding of the information being presented. The lunch and learn series, so we started by talking with the communities about the resources, including a book on how to care for a sick or injured child, followed by when to take a child to the emergency department, and lastly, what to expect when you get to the emergency department. 3 of the primary resources provided to parents, as I mentioned, one was the book talking about how to care for a sick or injured child, and then information about the Sanford nurse line, including a magnet that had the number to call, and details about how to use a symptom checker on the Sanford website. We asked parents to rate the usefulness of these resources provided, and all of the resources were identified to be at least slightly helpful, with a majority being identified as very helpful. We also asked parents to rate their comfort with the ED pre- and post-program participation, and found increased comfortability after participating in the education program. In terms of triage scores, we didn't find a significant change in non-urgent visits to the ED pre- and post-program. And then I will turn it over to back over to Susan for the next slide.
All right, so the last intervention development that I'm going to talk about is at our 3rd site, and this is very similar to our site 1, where the focus was really on the ED providers, so the physicians and nurses, and training in cultural communication skills. For this site, they had 2 things that they really wanted to focus on. One was sustainability of the program, and the second was ownership of the program. So they wanted to have a program that was internal and able to be used over and over again. So our hypotheses were the same, that by implementing our program, we would have higher scores from our providers and from parents. And we did work a lot, meeting with hospital employees, looking at a train-the-trainer approach. So our trainer from our first site, Jen Prasek, who did the work there, was able to do a train-the-trainer program at this site, so that we had what we termed health equity coaches that were available for physicians and nurses within the emergency department to use as a resource for cultural communication. So what we did is we did a series of in-person presentations, and then Jen also created a series of online presentations, again thinking about the sustainability. So we attempted to video all of our 4 in-person presentations to have them available, and then our online obviously is available online. And it is up on the CRCA website if you want to take a look at those. So the 4 presentations that we started out with in person to kind of introduce nurses and physicians and groups of the hospital to this study were on navigating culture and care, implicit and explicit bias, culture and healing in Ojibwe country, and then another one on unconscious bias in healthcare, looking specifically at how to improve patient relationships. The other thing that was different about this was our use of health equity coaches. So we had a 4-hour training to teach the health equity coaches about cultural communication skills and to have them be able to facilitate access to the online trainings and to be a resource for their colleagues. So currently we've completed all of the presentations. The web-based modules are up. We previewed one of the web-based modules within a staff meeting for our nurses at the hospital, and then our health equity coach connected with physicians and other provider groups to make sure that they were aware of the resources available. Right now we're doing our post-survey collection, so hopefully we'll have results on this soon. Now I'll turn it over to Brianna to talk about our last site.
All right. So I am from Children's Minnesota, and we also did an intervention. We called it the Impact of Health Equity Coaching on Patients' Perceptions of Cultural Competency and Communication in a Pediatric Emergency Department. So our research aim was to train emergency department providers as health equity coaches. And we assessed the impact of this intervention on patients' perceptions using a pre- and post-survey of emergency department patients, and also through a group interview with the providers who participated in this. So we were hoping that this would increase emergency department providers' knowledge and awareness of American Indian communities and health, to better relationships with American Indian communities, that it will be strengthened by participants sharing what they learned through a train-the-trainer approach, and that patients' perceptions of provider cultural competency and communication would improve. Our participants were 3 physicians, 2 nurse practitioners, and 2 nurses. They had been working in a pediatric emergency department anywhere from 5 to 15 years. One participant was multiracial and identified as American, Black, and white. And the other 6 participants were white. 1 was male and 6 were female. So we started with the patient satisfaction pre-survey, and then we moved into our educational lectures. At the same time as the educational lectures, which was from mid-September until mid-November, providers were also required to participate in service learning at American Indian community organization of their choice. The educational lectures started, the first one was on racism in medicine, and whiteness. The second one was done by the executive director of the Minnesota Indian Women's Resource Center, Patina Park, and that was a history of Native Americans and the federal government's policies around Native Americans and Native American sovereignty. And then the third presentation was done by our American Indian Community Liaison at Children's Minnesota, Lisa Shefty, and that was about current patient experiences at Children's. And it also talked about the disparities we see at Children's in our patient population. And then the fourth session was asking folks what they had learned and next steps moving forward. And then we did a group interview at the end of those educational lectures. In addition, we asked each cohort to present to their cohort what they had learned. So the nurse practitioners at their monthly meeting, the nurses at their unit council meeting, and the physicians at their physician meeting. And they also were asked to have 3 informal conversations with their peers about what they had learned. And then we're currently still in collecting the patient satisfaction post-surveys. So why service learning? We wanted to build relationships with the community where the hospital is located, as well as translating the knowledge that they're learning into actually interacting with people in the community. And also this was part of what our policy and advocacy team at Children's suggested and recommended. So the 4 top things that the participants identified as learning through this process, through this intervention, was that they got a lot of new knowledge about family structures in American Indian communities, just the vast knowledge that they did not have about American Indian history and historical trauma. And perhaps one of the most impactful things was the connection between the mistrust of medical staff and this history and current oppression. And then also another big learning for them was the institutional and structural racism that are present in our current healthcare system, such as how we establish what is normal lab values, the studies that have been previously done. So just a couple of findings from our group interview. The motivation for participating in this on behalf of providers was very high among the 7 people who did participate. And they cited that the lack of knowledge about American Indian cultures was part of that, and also that they would like and needed additional information about health disparities. So not just that they exist, but how do we actually address them? Some of the major findings from the educational content of the intervention was that folks identified that they didn't just not learn about American Indian history, but that they felt actually that they were misinformed about American Indian history. And that after participating in this intervention, it gave them positive interactions with American Indian families. I think one of the most powerful stories we heard was a provider who previously had assumed that everybody knew her intentions were always best for the family and for the child, but after learning about the history of the child welfare system and separating Native families, took some time with the patient that she wouldn't have otherwise taken time with. The family came in because the patient had fallen off the couch. And she had identified that her knowledge of this abuse of the child welfare system allowed her to slow down and just thank the mom for bringing the child in, telling her she did the right thing, and telling her that this happens all the time. So it was just a couple sentences that she was able to pull up and recognize as important in situations where she would have assumed prior that those would have been without saying. And then also, the service learning project, there was a lot of conversation about how this was really most beneficial for the providers and not necessarily the community organizations because it was very short. But that it did really provide people an opportunity to face some discomfort around communities that are close to the hospital and also close to where they live. So that felt really beneficial getting to get out there and interact with folks. And then on the dissemination of information learned, there was a lot of conversations about how beneficial it was that they were learning from Native people themselves in their intervention, and a lot of nervousness about disseminating that information as non-Native people back to their coworkers. Everybody did do it, and overall it went well, but there was a lot of acknowledgement that it wasn't going to be the same impact. And then additionally, one other finding that I want to share from the group interview that was really powerful is at Children's Minnesota, within the last 6 months or so, we put a uniformed police officer in the emergency department. So when you first walk in, that police officer is there. And one of the staff said that prior to the intervention, they were really supportive of that they felt much safer, they wanted to feel safer, that this uniformed police officer provided that. And then actually after this intervention, had gone 180 degrees and felt like that wasn't actually the best thing for families and that could impact care. So that was a pretty powerful change of perspective. So we have our findings. We have 2 emergency departments, one in Minneapolis and one in St. Paul. So we have some pre-findings that are overall pretty positive, both about, actually both sites. And we had about a 26% response rate total at both sites for the pre-survey. So we'll see what happens with the post-survey since our pre-survey ones were already pretty positive.
All right, so just a quick sum up. So we took a data-driven approach. So we took some time to think about what was going on in the communities, what was going on in the emergency rooms before we set out to develop interventions. And that, I think, was a very valuable way to go about it. Doing that, we were able to present directly to stakeholders at the sites and make some site-specific changes to make a workable program at their site. Because some of the things that we did in some of our sites, people were not happy at all about thinking about doing at another site. And so we just adapted to something that would work for them. We have some positive findings with our intervention. So some data suggests that we've made an impact on parent rating of communication among our providers. You heard some great stories from Brianna about the effect of the program on providers. We're still doing some final evaluations, so we'll see. Hopefully those will be positive as well. And as a group of interventions, our hope would be that we can show some positive influence in emergency care for American Indian children. And then I wanted to put up this huge list of people who helped out with the study from Sanford Research and Sanford Health, Children's Minnesota, Rapid City Regional, NIMHD, and all our community members. So a ton of people involved. I'd like to especially thank Jen Prasick, who did all the training at all of our sites, Katie Burgess, who came up with using the IAT for our study, and then our colleagues at Children's, Dr. Payne and Carbonda, who provided the medical perspective for our study. So thanks. Should we stay up here?
Great. So if you guys could stay there, we have a few more minutes left for Q&A for all our 3 research projects. If Anna's around. Wonderful. Questions? There we go.
I know that some of the motivation that you said was they just wanted to learn a little bit more, but I've always found, was there any other types of motivations that you used to get people to actually come to the trainings and be a part of it? Because a lot of times I notice with larger organizations, they think, oh, this is just another racial training. I don't know if I really want to be here. So I'm wondering if there was any other kind of motivational things. Did you have food? What all did you get to get them there?
Well, I can start really quick, which is that we did actually pay providers. We actually paid the providers for participating. Yep. We did.
And we also paid them. We paid providers in cookies. In cookies and coffee. But we also had buy-in from some of the leaders in the emergency department who very much encouraged people to come to the presentations.
Can you clarify, when you say you paid them, you mean they were on the clock? It was work time?
No, it actually wasn't work time. It was a separate payment. So we had a lot of support as well in the emergency department and felt like we wanted to use some of those resources to ensure that they actually did follow through with all parts of the intervention and did show up. They were required to participate in every single session. So we offered them a stipend, essentially.
And I should say, too, for our health equity coaches at one site, we did have funds available to pay part of their salary for that work.
I noticed that you said that there was some classroom training for the nurses, and maybe I missed it, but was there any kind of training for the physicians or advanced practice or other professionals or even ancillary staff in the ED?
So for that site, the classroom-based training was just for the nurses. We didn't find a forum to do advanced practice providers or physicians. But they were part of the shadowing program, and so we had some physicians and we had some people who worked at the front desk participate in that as well.
I got a country voice, so I won't get it. Do you present at the American Indian Physicians Conference?
Oops. Okay, there you go. For the emergency department study, we have not presented at AAIP.
Yeah, I've visited AAIP quite a number of years. I wouldn't be able to speak to this program, but it seems like it would be a good bit of results to present there. I did present some of our results from the asthma study a couple years ago when I was there. I just wanted to make a quick amendment too. I forgot to mention some of the connections that occur as part of the research. Mr. Joe Irsheta will be continuing his training under a PhD program with Anna Navas-Asian. So I think that's another really interesting and exciting advance of what we're doing in terms of the networking for our studies.
This is go ahead.
Regarding presenting, I haven't myself. I didn't present for the American Indian Physicians Conference. I haven't presented there, I think it will be great because I think understanding the environmental risk factors for disease is very important. So I thank you for your suggestions. I think it's an important one. Last year I had the opportunity to participate in the research symposium that Marcia O'Leary and Missouri Breaks organized at the Cheyenne River. So that was actually great because the feedback we got, the questions, it was very dynamic. That I felt really very useful for me, myself as a scientist, to have that opportunity to present in that venue. And then last year we also had this, with the Sanford study, we did a community workshop, and community members from all the tribes actually came together. We met in San Antonio, Texas. That's a center where all the biospecimens, not all of the biospecimens, but for the DNA material for the genetic studies are stored. So the community members had the opportunity to see the freezers, where all the samples are. Everything was explained to us. Even the computers were, for do the genetics research, and they've taken into account the family structure of the Sanford study. And being able to do that research well, you need these computer clusters that are extremely big. So I think it was very useful for the community members to attend and be there together with scientists, and we all had a great time together. So I think this type of opportunities to mingle and being together, community members and scientists, and talk to each other, I think are really good. So thank you.
My question is of Susan, Brianna, and Wyatt. You chose one half of the provider-patient dyad. And in fact, I think the literature is becoming increasingly clear that that's probably the more difficult half to actually impact and the kinds of encounter dynamics that you're looking at. I wonder if you could think a little bit about the other half of the dyad, that is the patient side, admittedly a child or adolescent, but probably with a guardian or a parent accompanying him or her. I know, for example, we're doing work with values affirmation on the part of patients, youth as well as adults, in which is a very simple 5-minute intervention that gets the patient to pick 3 core values that they believe are absolutely essential to who they are, and to write a sentence about each. And then they go into the encounter subsequently. And the data is pretty clear about this, particularly in the educational context, that but in the healthcare context, it's certainly shown in randomized controlled trials an important impact on differences in adherence to treatment recommendations, satisfaction with the encounter. Ironically, in the part of the patient, and less so in the provider, but what you're basically doing is probably equipping the patient to be more assertive, self-informed consumer of the healthcare. So I'd be really interested for your reflections about, if you were to look at the other side of the clinical dyad, what your thinking would be.
That's a really great point, because the interaction does go both ways. We didn't get at that as much as we could have. We did get at it a little bit in the site that we did the community intervention. So trying to introduce people at least what to expect in the emergency department. The lunch and learn sessions were done by hospital staff who were in the ED to try to get people familiar with faces of who they might see there. We had thought about doing visits to the hospital and the emergency department to get people involved, but we didn't go that one step further in thinking about like positive affirmations or things that people could do before going into a visit. But that's a very good idea and a good point.
Really great presentations. Thank you all. I'm wondering, I'm interested in the implicit bias aspect and any effort or interest in connecting. We, in some of the past work that I was involved with NCAI, we were looking at ICWA and some of the work, particularly in Tulalip. Stephanie Freiberg was leading up some efforts there to work with child welfare staff within the tribe to really talk amongst themselves about the implicit bias and how that affects their provision of services, which really just opened up a whole new culture of discourse and way of kind of owning and growing through some of that. But also, I forget his name, but Philip, he's out of Sanford University, and African-American researcher looking at law enforcement, Phil Goff, thank you, looking at voluntary opportunities for law enforcement to step up and say, we know we have an implicit bias issue, and here's how we want to work to address it. So kind of thinking about cross-disciplinary links of this work, but also how the findings and the insights that you're gleaning might have broader impact across the board.
That's a very good point too. When we got our results back and we found that implicit bias was the same when you're looking at pictures of adults and of kids, I did kind of a deeper dive into other areas to try to understand why that would be. And I did look at more of the law enforcement. I looked at the educational system. And it is the case that this bias exists in people who work all the time with kids. And so we really ought not to have been surprised by that result. But I think there is great opportunity for cross dialogue between different regions and how to do this. And I do have to say that the nurses and physicians were awesome and were really open to doing some of this work. It's not easy to say I might be doing something that whether it's unintentional or not that might affect how I treat my patients, and that's not an easy thing to find out.
I think too the cross-disciplinary is really important. I know just from our providers talking about how emotional it was to find out their results when they're in a job because they're trying to help people and they're trying to help kids and they deeply, deeply, deeply care. That them doing some of their own research and learning about other places where implicit bias exists. Particularly, one of our providers talked about a study of African-American preschool teachers and their implicit bias against African-American preschoolers helped them sort of be like, okay, I can talk about this, I can acknowledge this, this exists outside of me, outside of children's, and maybe by us being willing to do this work, like even though it feels very vulnerable to say, hey, look at all the disparities at children's, like doesn't seem like good PR. But that maybe by opening up that vulnerability and being willing to look at it and work on it in the long run, like we will be able to address it more efficiently, more effectively.
Hi, I'm Joe Rochetta. Thank you for the shout out, you guys. I also wanted to point out that Dr. Best and I are partnering now with Dr. Carlos Bustamante and Esteban Burchard's one of their students, and they've been working on this asthma project in Latinos, and so they did Mexicans, Puerto Ricans, and Cubans, and in that study they determined that Indian ancestry, American Indian ancestry, actually protected against asthma, and so in this context it seems to be the reverse. And so by doing a comparison of the two groups in different environmental and social contexts, you'll get to a better or a clearer picture of why asthma prevalence goes up or down, and to that possible association, I wondered if either Dr. Best or Dr. Navas-Acien could talk about the possible things that would lead to inflammation, like arsenic exposure or mercury exposure or any kind of other exposures that might be happening that might exacerbate the potential of asthma and obesity.
I think it's a great question and a difficult one, and it connects with what I commented earlier of this data sharing and working together. Because when you have different populations, then you are able to check if there are differences in the disease. What is it? Is it are there some genetic explanations for those differences, or are there environmental explanations? And I think the environmental explanations are often more important, or at least in what we know today, in how much disease variability is explained by genetics versus environmental. In general, but again, you will need to have good measures of those environmental exposures that are relevant. So if you have the biomarkers, then you'll be able to look at arsenic, at mercury or at other like secondhand tobacco smoke, or even other things like social stress and other determinants. So I think you need to, by having that information, then you'll be able to, having the questions, being able to answer. So I didn't provide you a very good answer to your question because it's a difficult one, but thank you for asking it.
I'd just like to add a little bit along that line. In spite of the fact that I'm terribly interested in genetics, and I think it can contribute a lot to our understanding of disease, I agree with Dr. Navasasian. I think the contribution of genetics to disease is a relatively small part of what we see in the population basis. I mean, we certainly have some diseases where it's very clear that, having a particular mutation causes very serious problems in almost everybody. But the vast majority of conditions like heart disease and diabetes and asthma and so on, there's probably a contribution from genetics, but it's relatively small. I think the value in studying genetics has to do with understanding more what the physiology is, what the biology is, and that might help us to understand how to treat it better or to prevent it. And so I think it's not about trying to find out why some particular group has more asthma or has more diabetes or whatever because of their genetics. It's more about what can we learn from genetics that will help to treat and prevent the disease. So that's my disclaimer.
Great. Well, I think we'll leave it there if we can give a round of applause to our wonderful research projects. And we'll have Amy Elliott give a little close before we move to the next thing.
Well, it's a very little close. I think you guys may have heard the sound of some bells going by. And so thank you for joining us today. I hope you're able to come back tomorrow for another really good day for presenters. And right now we're very pleased, and it'll be in the East Bay, again, where we ate lunch, to provide a wonderful showing by the Native Pride dancers. And so really a perfect way to end just a great day. And so the mission of the Native Pride dancers is to educate, inspire, motivate, and empower diverse communities to bridge cultural gaps through Indigenous traditions. So I hope you're able to join us. We also have some food, some appetizers, but I can make a dinner out of that. I don't know about you all, but so please join us for just kind of a celebration to end a great day. So thank you.